The ouch study. Adverse events occur with all therapeutic approaches. The assumption, though, is that it has to be a real therapy approach to result in the report of an adverse event. Yet past research indicates that sham therapies also have an adverse event rate. That's right, even though the therapy is not real and should have no effect, therapeutic or otherwise, it still does. What is unknown is how much of this is attributable to simply the artifacts of natural history for the presenting problem, and how much is related to the patient's belief that they're being treated. Also, the assumption has always been that if there are adverse events related to sham treatment in studies, that it will be demonstrably lower than for the real therapy. A new study investigates these ideas as they relate to chiropractic care. Of participants in studies evaluating adverse events with chiropractic manipulation, 34 to 61% experienced at least one adverse event. As we know, the vast majority of these events have been shown to be benign, such as headaches, muscle stiffness, tiredness, or radiating pain, and short-lived, with most resolving within 48 to 72 hours. Some individuals question whether adverse events are underreported, because in previous studies, chiropractors administered the questionnaires, which potentially introduces bias given they were the same individuals performing the treatment. And recall bias is also possible given many of the studies were retrospective studies. So given there is such a high rate of adverse events, are there predictors that may be utilized to avoid these events? In previous studies, the following have been shown to be predictive to some degree: being of female sex, age 27 to 46 years, if high-velocity manipulation is utilized compared to low-velocity manipulation, the first treatment, if the patient is using medication, if more than one region is being treated, or if only the thoracic spine is treated, if the treatment includes cervical rotation, the patient's work status, and if a general practitioner visit occurred in the previous 6 months. Yet there is no single predictor that is consistently dependable. Also, no study to date has evaluated the role of placebo or natural history on the percentage of occurrence of these adverse events compared to usual treatment. Well, until now. The title of this research publication is Outcomes of Usual Chiropractic, the Ouch Randomized Controlled Trial of Adverse Events, published in Spine in 2013. This Australian study utilized a parallel group randomized controlled design. It was conducted over a 3-month period at metropolitan chiropractic centers. Participants were randomized to either a sham group or a usual care group. Researchers measured the following: demographic and clinical characteristics of the participants at entry, adverse events at 2 days after each of the 2 treatments, and they evaluated the success of blinding at a 2-week follow-up. So how were adverse effects assessed? Well, participants were asked, quote, "Did you experience any new unwelcome symptoms or an increase of your presenting symptoms during the first 48 hours after treatment? Yes or no?" Further detail about any adverse events were obtained by 4 open and 4 closed-ended questions about increased pain, muscle stiffness, headache, and radiating discomfort. Each adverse event was assessed with an 11-point numerical rating scale for pain and for the onset and duration of the event. Participants completed the adverse event questionnaire 2 days after each appointment and returned it by mail. Let's review the inclusion criteria. The participant was 18 years of age or older, had nonspecific spinal pain of at least 1 week duration. They scored at least a 3 on the numerical rating scale for pain and a 17 and 12 on the functional rating index. In addition to the usual exclusion criteria, the researchers were clever in screening for potential bias, excluding participants who believed that they would be unable to tolerate any chiropractic management therapies. Let's look graphically at how chronic this group of participants was. Here we see that about 98% had pain for greater than 3 months and 75% greater than 5 years. We also see that for about 95% it had been 1 year since their last 4-week pain-free period, and not shown here, about 70% stated it had been 1 year since their last 1-week pain-free period. So what is a sham treatment in this study? Well, the treating doctors used detuned ultrasound, and the doctor applied a randomly placed hand on the spine while ultrasound was administered to give a, quote, hands-on experience. Also, an activator instrument set at the lowest setting was applied through a tongue blade as the sham adjustment. Usual care varied among practitioners, but included the following and their percentage utilization. Manipulation, 96%, soft tissue therapy, 64%, mobilization, 52%, range of motion exercise, 51%, strengthening exercise, 5.5%, and traction and heating in 1%. Both groups were treated 2 times with about 1 week between treatments. You can see here the percentage of adverse events. In the sham group, 33% had 1 adverse event compared to 42% in the usual care group. In the sham group, 71% had more than 1 adverse event compared to 77% in the usual care group. For increased pain, 29% of the sham group and 36% of the usual care group. For muscle stiffness, 29% in the sham group, 37% in the usual care group. For headache, 17% in the sham, 19% in the usual care group. And for radiating discomfort, 15% in both groups. 51% of the adverse events in the sham group and 41% of the usual care group persisted for less than 24 hours. Risk ratios for experiencing an adverse effect, whether moderate or severe, were not statistically significant. However, the power of the study may have limited the ability to detect this. Well, let me explain further. Previous studies have shown a difference in adverse effects to be around 40%. That is, 50% for chiropractic on average and 10% for detuned ultrasound. Researchers then, assuming an alpha level of 0.05, knew that recruiting 180 participants would provide 80% power to detect a difference of 20%. The difference between groups in this study, though, was less than 20%. Said another way, the study may be underpowered because of too few participants to detect a real difference between groups if that difference is as small as indicated in the results of this study. Another potential concern was blinding in this study. 67% of the sham group and 85% of the usual care group actually guessed the group to which they were randomized. Something referred to as the Bang Index value showed that 25% of the sham group and 61% of the usual care group guessed correctly beyond what would be expected by chance. You would think, though, that this would have decreased the reporting of adverse events in the sham group. Finally, let's discuss patient expectation. Studies have indicated that providing information about the risks of adverse events increases the likelihood of adverse events occurring. Conversely, providing information in a positive light, such as stating that adverse events are almost always benign and short-lived, can lead to a lower reported adverse event rate. Interestingly, this study, other than stating that patients signed an informed consent, gave no indication how or if information regarding adverse events was given. Yet, they recommend that based on the results of the study, language be developed that would reflect that adverse events are generally benign and short-lived. So, what can we conclude if this study's results reflect reality? Adverse events result from either natural history variation or nonspecific effects related to chiropractic management of spinal pain as often or almost as often as do those related to the treatment itself. We look forward to further investigation of this phenomenon in larger studies.